Hi, good afternoon. Welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn. It's 12:30 on a beautiful Thursday afternoon, and we are really delighted to have our chair of orthopedics giving us a talk today. Tim Foster is going to be talking about rotator cuff disease, and of course, you can apply for CME for this talk. Tim, next slide, please.
Oh, I'm not advancing. Sorry. Here we go.
Thank you. The code is up there, GEWZUS. I'll put that up at the end again. Once again, it's typically gotten through texting the daily code up there. People have asked me if the code is still good. The code is good for 1 week after the talk. So if you go and check out our talk on YouTube, you can definitely still use the code. Next slide, Tim. As usual, I want to tease the next couple of weeks. Next week we'll be talking about updates in prostate cancer, and the following week we'll have another shoulder talk by Jay Simon. So we're excited about that. Again, these are all archived up on YouTube. Newton-Wellesley Medical Group Lunch and Learn is all you have to do, put in the search bar at YouTube, and all our talks will come up, and you're welcome to kind of peruse them. And okay, next slide. I think that's it for me. I'll let Tim do all the talking about rotator cuff. Thanks for joining, and I'll come back on at the end. All yours, Tim.
Okay, here we go. Thank you very much, John, and thank you, Audrey, and everybody else. I really appreciate being here today. I have no disclosures. This is who I work with. These are my colleagues, Dr. Robert Nascimento, myself, and Dr. Jason Simon. We live, eat, and breathe shoulder and sports medicine. We take care of professionals teams. Bobby Nascimento will be with the New York Jets. Well, he's with the Patriots, but he's at the Jets this weekend. I'll be in Syracuse, New York with Boston College. Jay Simon used to take care of the San Jose Sharks farm team. So we live, breathe sports medicine and shoulder surgery. And if you look at all our advanced degrees, if we're not good shoulder surgeons, we can certainly do your taxes. So here we go. This is all going to be case-based learning today. And I think at the end of this 30 minutes, we're going to look at 3 cases. And I think at the end of today, you're going to have a really good idea about rotator cuff disease. So let's talk about the first one. 50-year-old male surgeon. It's his dominant shoulder. He injured it on an obstacle course where he fell directly onto his shoulder. His symptoms are not better after 6 weeks with relative rest. He has night pain that goes down the lateral side of his arm. He has pain when he elevates his shoulder. He can't throw a ball to his kids, but he can still operate. He can still keep his hands in front of him and operate almost like somebody would work on a computer. And he wants to know what's his prognosis and should he have surgery or not have surgery. So if you remember this from about 10 years ago, you make the call. Was the player inbounds or out of bounds? I'm going to ask you to think about what you would do, how you would counsel this doc as to what he should do. And in order to counsel him, you're going to need some more information. So here we go. This is his MRI scan here. And you can look at the cursor here. You can see my cursor. This is the humerus, and this is the glenoid over here. But this is the rotator cuff. This is the torn edge of the rotator cuff here. And it belongs, all this white is fluid. That torn edge belongs all the way over here. That's a really large tear of the rotator cuff that this guy has. And here's a coronal view, and this is a fat suppression. You can see, once again, torn edge of tendon right here. That torn edge of tendon should be going through all this white fluid all the way over to the lateral side of the humerus here. He has about a 2 to 3 centimeter tear. This is his glenohumeral joint, which looks pretty good. But if you also look very subtly, right under the acromion, the bone on top of the shoulder, there's this little piece sticking down also. So this guy was probably predisposed to having something wrong with his rotator cuff in the first place, because he has an acromial spur. But from the obstacle course, he now has a complete tear of the rotator cuff. So, and this is just a sagittal view, and you can see all the white fluid here. This is the back of the rotator cuff. This is the infraspinatus and teres minor, but this should go up all the way over his shoulder with the supraspinatus, completely cover his shoulder here, and it's not. It stops right here. So once again, complete, pretty big tear of the rotator cuff for a relatively young person. This is a really important view. This is one of the sagittal views, and we're going to talk about this a lot today. This is the muscle of his supraspinatus all in here, and this is actually really a good amount of muscle for somebody who's 50 years old. So this is something we look at very closely, and I'm going to show you why we do that. So first of all, let's see what we're talking about. Talking about the supraspinatus is completely torn. This is the acromion up here. So complete tear of the supraspinatus. And this is where it should be attaching. It should be attaching on the paint, on this green paint right here. All that should be filled in by the supraspinatus, but instead, that supraspinatus is way over here. And this is what it looks like graphically. So you can see here, torn supraspinatus tendon. Side view, once again, complete tear of the supraspinatus. So in order to be able to treat this gentleman, we have to know what the natural history of rotator cuffs are. So number one, all rotator cuff tears, all of them progress over time. Even partial thickness tears progress over time. Asymptomatic tears, meaning obviously people who have no symptoms whatsoever, progress at a slower pace. But when people have symptomatic tears, it makes you wonder if they're really progressing very fast with the rotator cuff. And when I mean progression, I mean that the size of the tear is getting bigger and bigger and bigger. The other thing that you need to know to treat this person is that there is no inherent healing capability of the rotator cuff. Once that rotator cuff is torn, it's not going to be able to reattach itself onto the humerus. Once it's torn, and once again, the tears progress over time. So what happens if tears progress? Let's take that surgeon that we have. Here's the humerus, here's the glenoid, here's the edge of the tear. If we let that tear go over time, the tear begins to retract back toward the glenoid. So here's the edge of the torn tendon. That needs to be pulled all the way over here. So essentially that gap gets bigger over time. It becomes very challenging to do that surgically. So you get retraction and fatty infiltration of the muscle. Remember that sagittal cut I showed you before, that it was completely filled with muscle of the supraspinatus? Once again, here we are, the sagittal cut of the supraspinatus muscle. There's almost as much fat as there is muscle in the supraspinatus. And this is a very poor prognostic indicator. And what's worse than that, it's irreversible. Even if we were to repair his rotator cuff now, he may not have enough muscle quality to drive that repair. So this is specifically staged, how much fat there is compared to muscle. And we look at this very closely before we make a recommendation of whether somebody should have a rotator cuff repair or not. Most people, even a 50-year-old, are stage 0, where there's a normal amount of muscle without any fat. This fella is probably a stage 2 or 3, where it's almost the same amount of fat as muscle now. So, and as you go down to stage 4, it's a very poor prognostic indicator. So once again, we look at this very closely. It's just not the fact that he has a torn tendon. It's what's the muscle doing? So tear progression, this is a take-home message. Every pop-up is going to be a take-home message. Tear progression leads to undesirable, irreversible consequences. So what about PT and other factors? So what you also need to know is that 50% of patients who have a full thickness rotator cuff tear, a degenerative tear, we're going to get back to that, will improve with range of motion and pain with just PT alone in 6 weeks. They get better, they get functionally better, their pain goes away, they can sleep at night. 75% of patients get completely better. They still have the tear, don't forget that, that's not going to heal, but they've accommodated for it. 75% of patients get better by 12 weeks. And then the other 25% after that usually don't get better. But here's the deal with this patient, and this is something that you should remember, all the PCPs and family medicine docs, everybody out there. A traumatic tear is a bad actor. So somebody who has a fall, for example, a fall on ice, or this gentleman was on an obstacle course, a fall, a traumatic tear is a bad actor. And what a bad actor means, I think everybody recognizes Jack Nicholson from The Shining, right? He's a good actor. But traumatic tears are bad actors. There's a high probability for rapid tear progression. And if we're going to operate on somebody very quickly, it's usually somebody who has an acute tear of the rotator cuff because it can retract very quickly and the patient can have significant damage. So you make the call. Would you operate on this gentleman? Would you not operate on this gentleman? I think we would all agree based upon what we've seen. He has an acute tear. He has no muscle atrophy. It's a pretty big tear that we would probably say he should have this repaired. And so this is indeed the video of what it looks like during the repair. This is just an arthroscopic grasper. We're doing this through a scope. We're grabbing the torn edge of the rotator cuff here and pulling it back to where it belongs. That's the muscle. This is the humerus over here. That rotator, it's like pulling the sheets up on your bed. That's what I tell people. We need to pull the sheets up on the bed onto the humerus. And we're doing this arthroscopically. But I want to stop for just 1 second. If you look up here, we're going to talk about this next. This is the coracoacromial ligament. You see how frayed this ligament looks? This is a sign that this person has had chronic impingement for many years, that he's frayed this ligament because his rotator cuff is banging up against the ligament and his acromion. So that's our torn rotator cuff. Once again, big tear, it belongs over here. This is where the green paint would be on that diagram. That's the way it should come back. Now, the radiologist has also read this, and they'll read almost everybody whose shoulder is over 40 years old as a tear of the anterior glenoid labrum too. So this is what the anterior glenoid labrum looks like. I just wanted to show you this. This is a frayed anterior labrum. The labrum is simply a piece of cartilage that goes around the socket, that goes around the glenoid. And in everybody over 50, whether they fell on an obstacle course or not, they're probably going to have a torn labrum when the radiologist reads this. So I just wanted you to be aware of that and show you what that looks like actually arthroscopically. So here it is. That's what a torn labrum looks like. Sometimes that's pathologic. Most of the time, that's not pathologic. And so finally, just to show you what we did with this gentleman had an arthroscopic rotator cuff repair. You can see the sutures in the rotator cuff, and that's brought back over to the footprint, to the green paint. And we're going to show you a better view in just 1 second of what that looks like. You can see all the sutures bringing the rotator cuff down to where it belongs. So, and he's gone on to have a really good outcome after the rotator cuff surgery. So we'll leave that. And the results of rotator cuff repair in the right people is very good. So let's go on to case number 2. We have a 70-year-old active female with left shoulder pain. She's had night pain for 6 months, pain with overhead activity. She can no longer hook her bra in the back. And this is a very common complaint that I hear from females. I can't internally rotate and hook my bra in the back. I have to hook it in the front and switch it around. So she's lost internal rotation. 3 months ago, she became much more painful with restricted range of motion. There's no history of trauma with her at all. This is what her plain X-ray looks like. So let's talk about plain X-rays. She has a good joint space here. There's no calcium deposit over the greater tuberosity, so she doesn't have calcific tendonitis. That's one thing we certainly look for. This is a pretty good looking X-ray. And this is called a scapular Y view. And I can follow the shape of the acromion here. And she has a little bit of a down-sloping acromion, so she may have some impingement here. And this is what a real down-sloping of the acromion looks like. You see this big, this is a stalactite literally sticking into the rotator cuff here. The rotator cuff is coming through this clear space. This is a stalactite sticking into the rotator cuff. So we have a pretty good idea that this person has impingement syndrome, impingement against the acromion here. So let's look at her muscle quality. What do you say about her muscle quality? Just think to yourselves, looks good, right? There's no fat. I don't see any fat here at all. This is all good supraspinatus. That's good. Let's go over to the coronal cuts. She's got these morphologic changes in the tendon that I would expect any 70-year-old to have. I probably have this. most of the people in the audience have changes to the rotator cuff. If you look closely, she's got this little spike of bone coming down that's compressing her supraspinatus. But this is not a tear of the supraspinatus. So she has rotator cuff impingement, and on the spectrum of rotator cuff disease, this is more toward the milder side. So she has atraumatic pain, pain with overhead activities, pain with abduction and external rotation. So patients will have pain as they bring their arm back like they're going to throw a baseball. This type of motion is painful to the patient. That's called Hawkins sign, is painful to the patient. Straight up pain is called Mears impingement sign. She has pain with sleeping at night and disturbed sleep, and we see that all the time. Pain goes down the lateral aspect of the shoulder, down, it radiates down toward the elbow. A few cases actually go past the elbow, but not into the hand. So based upon her exam and her imaging, she has impingement syndrome. So here's that coracoacromial ligament I was telling you about in the last patient that was frayed. This can pinch up against the supraspinatus. It creates a reactive bursitis in the shoulder, and it causes pain. So patients with rotator cuff disease can also have secondary adhesive capsulitis with restricted range of motion. The impingement sets up this whole inflammatory cascade within the shoulder. And that inflammatory cascade causes secondary frozen shoulder. Frozen shoulder didn't come first. It's because of the chronic impingement syndrome. So what about our treatment options with this patient? She went to physical therapy for months and months and months, and she did not get better. This is not a picture of her, but you can see this is what therapy focuses on. They just don't focus on range of motion. With the shoulder in this position, the scapula is protracted forward. What the therapist works on is opening up where that rotator cuff lives under the acromion by bringing the shoulders back. And they work on this, and a lot of patients get better just from the therapy alone. But we could also do something called hydrodilation. Hydrodilation is putting saline into her shoulder to expand her shoulder capsule like a balloon. And that treats the adhesive capsulitis, but it doesn't treat the impingement syndrome. And what about a corticosteroid injection or arthroscopic surgery? So corticosteroid injections are fine. They're certainly not for acute tears. They should never be done proximate to surgery, meaning if you inject cortisone 3 months proximate to shoulder surgery, we're worried about infection in those cases. So we typically wait for some time after somebody's had a cortisone injection. It decreases the inflammatory response of the subacromial bursa. But the bad thing about cortisone is that it inhibits the transcription and translation of the matrix proteins of the rotator cuff. So the code for that is that it can accelerate the progression of a tear if people have too many corticosteroid injections. So 1 or 2 corticosteroid injections is probably fine, but it also limits the molecular growth factors in the subacromial space. And we did a study, when I was at Boston University for over 20 years, we did a study looking at this. The more patients have cortisone injections into the shoulder, the less of a chance the rotator cuff is going to heal once it's repaired. So we're a little bit cautious about that. Arthroscopic surgery in this case is only for people who have failed conservative management. It's not frontline treatment for people with impingement syndrome. And this is what a normal shoulder capsule would look like. This is what the shoulder capsule of this patient looked like. You can see how red and inflamed. This is what adhesive capsulitis looks like. Once again, it's not due to the, it's not primary adhesive capsulitis, it's due to the rotator cuff impingement. So what we do is we make an incision in the shoulder capsule, and it opens up the capsule. Here's where we had made the incision with a bipolar device. It opens up that shoulder capsule and gives the patient instantly more range of motion. Simultaneously, what we do is we remove the bone spur under the acromion. So this is a flat acromion now. These are our shavers that we use to do this. This looks gigantic, right? This is only 5.5 millimeters. So we shave down the undersurface of the acromion. It never grows back, but it gives the patient more room for the rotator cuff. And that's exactly what this patient had done. She went to therapy religiously for months and months and months, had a cortisone injection or 2 and did not get better. So she ended up having the surgery. So here's the last case, and then we're going to go to questions. A 57-year-old right-hand dominant male, persistent right shoulder pain for many years. He remembers some injury when playing sports when he was in his 30s, difficulty with overhead activity for many years, but the guy still plays in a basketball league. Can't sleep at night. He works as a bus mechanic for the MBTA. He's had previous rotator cuff surgery, which is remote. He was doing okay for several years, but he's now limited with range of motion. He can barely raise his arm. So what do you think of this? So here's the sagittal cut. You guys can now be the experts, right? You can make the call. Look at his muscle. This is a big guy, by the way. Look, he's like 6'4". Look at his muscle compared to the fat. This is significantly atrophied muscle. Another surgeon was all set to try and do a rotator cuff repair on this gentleman. And unfortunately, this would not have worked due to the loss of muscle here. So this is a picture of what his shoulder looks like. Here's the glenoid or socket. Here's the humerus. He's got a little bone spur here. This is from the previous surgery. And his humeral head is elevated, meaning his humeral head and the socket, the glenoid, are no longer aligned. And here's that rotator cuff edge of tendon way back here. That needs to go all the way over to the lateral side of the humerus. So he has a lot going on here. He has poor muscle quality. His humerus is elevated due to the lack of the rotator cuff holding it down. And he has a huge tear of his rotator cuff tendon. So a take-home message is patients with traumatic or degenerative tears can have pseudoparalysis, which is the inability to elevate the arm due to rotator cuff force couples. And this can happen with acute rotator cuff disease or chronic disease. If you have one tendon torn, you typically can still elevate your arm. But if you have two of the four rotator cuff tendons, it depends on which two, you may not be able to elevate your arm at all, and you have what's called pseudoparalysis. Obviously, it's not a neurologic problem. It's because of the force couples of the rotator cuff. And this is an example of what the force couples of the muscles look like. Subscapularis here, supraspinatus, infraspinatus, and teres minor. And this is the resulting vector. If you tear your supraspinatus and subscapularis together, by the way, you would typically have pseudoparalysis. So it's what changes this vector force with the muscle pull can really affect whether you can elevate your shoulder or not. And there are people who go on for years who have rotator cuff tears that are never repaired, and they're doing just fine. But once they tear another tendon, they can then have pseudoparalysis. So you make the call. Is this person a candidate for rotator cuff repair? The answer would be no, right? He's got too much cuff atrophy. It's a predictor of a poor outcome. His humeral head is up, predictor of a poor outcome. He has degeneration of the glenohumeral joint. He has a retracted tear with multiple tendons, grafts, patches, stem cells. I love Joanne Borkstein, by the way. Joanne is absolutely fantastic, and she is wonderful with stem cells and PRP, but in this case, that's not going to play any role. So the only thing that we could offer this patient would be a reverse total shoulder replacement that uses the deltoid muscle, it completely bypasses the rotator cuff. So this is for people who have massive rotator cuff tears that just can't be repaired. So this is, you can see where the ball is. The ball is actually where the socket used to be, and the socket is where the ball used to be. So reverse total shoulder, it uses the deltoid muscle, doesn't use the rotator cuff muscles at all. And this is what it looks like. And my colleague, Jay Simon, is going to talk about this in 2 weeks, and I'm sure he's going to talk a lot about reverse shoulder replacement. So my final tips to you are, when you're probably saying, when should I refer a patient? Well, if somebody has a traumatic injury and they can't elevate their arm, I would say that patient should be referred right away. That is very time sensitive. Restriction of range of motion or pseudoparalysis, we should probably see the patient. I often hear, should I get an MRI first? What about x-rays? And my response would be, let us evaluate the patient and decide which imaging is best. Sometimes we actually get CT scans. Sometimes we get MRIs with contrast. So it's nuance. But if there's any concern for a fracture at all, please get an x-ray. By the way, we also take care of fractures of the proximal humerus, fractures of the glenoid. That's our thing as well. So we will evaluate anybody the same day or the next day. We're at 978. And at 978, by the way, we're also starting this orthopedic urgent care. We're not going to call it urgent care, but it's going to be Ortho Express or Urgent Ortho. And the whole idea behind this is going to be patient focused with off hours, meaning evening hours, weekend hours. It decreases the total medical expense. It opens the funnel so people are not leaving our system, going somewhere else. And it decompresses the ER for things that we're really happy to see. And hopefully we're going to get this open on January 1st. So I'm not sure how I'm doing on time. I was going to tell you a little story. Let me tell you a really quick story and then we'll take questions. So E.A. Codman is a hero of mine. E.A. Codman was a shoulder surgeon at the Mass General back in the 1900s. So he wrote the first article. I went to Kentway Library and found this. He wrote the first article on a ruptured rotator cuff. And one of his patients was Mrs. J.A., aged 52. She was from Scotland, and she was hanging out her laundry when she felt a pop in her shoulder. And he operated on her and found that she had had a torn rotator cuff. And what I find humorous about this, first of all, is that this is only 100 years ago. The first rotator cuff was done 100 years ago, which seems amazing to me. And then I'll tell you a little bit more about Codman in a second. He was followed at the Mass General by Carter Rowe. And this is Charles Neer from New York, who really pioneered shoulder replacement surgery. Carter Rowe was a pioneer of rotator cuff tears and shoulder instability. And I was his last fellow in 1991. And what a gentleman he was, and what a master surgeon he was. And it was just an honor to have him as a mentor and a teacher as well. He did not even conceive of doing any of this arthroscopically, but we have taken all the principles from open surgery and we can now do all of them arthroscopically for rotator cuffs. So back to E.A. Codman. E.A. Codman wrote this. He said, the common sense notion that every hospital should follow every patient it treats long enough to determine whether or not the treatment has been successful, and then inquire, if not, why not, with a view of preventing similar failures in the future. He was the first one to think about outcomes. He was an orthopedic surgeon, but the first one to think about outcomes. And he drew this cartoon for the Boston Medical Society in 1911 and was just about thrown out of Boston, meaning that surgeons had their head in the sand and doctors had their head in the sand because they didn't want to know about what happened to the patient. They would just operate on the patient and really didn't know what happened to them. So he was one of the first ones to think about this. But here's the interesting story that you'll now know the rest of the story forever. In 1917, on December 6th, there was a huge explosion in Halifax, Nova Scotia. An ammunition ship during World War II collided with another ship and it exploded. There were over 200 tons of TNT in one of the ships. It was the largest explosion in the world except for the atomic bomb. Over 2,000 people died. It completely devastated Halifax, Nova Scotia. Halifax, Nova Scotia was leveled during that time. E.A. Codman got on a train from Boston and went to Halifax, Nova Scotia, and he stayed there for 3 years. There were many people who had amputations, many people who were mutilated due to the explosion. He stayed there for 3 years and operated on those patients. In return, Nova Scotia has sent a Christmas tree, a holiday tree, to Boston every year for the past 100 years, and they still do it today. So when you see the Christmas tree in the Prudential Center or outside the State House, and it's from Halifax, Nova Scotia, now you know the rest of the story. Okay, questions?
Thanks. Thanks, Tim. That's awesome. Great talk. Love the pictures, and definitely I love that historical little tidbit at the end. I don't see any questions in the chat box. We're coming up against 1 o'clock also. If someone wants to unmute themselves and ask Tim a question, I'll give 1 minute for that. I'll put a plug in for that urgent ortho clinic that we hope to open on the 1st of the year. That is going to be a great way. And also, don't forget, next week our talk is about prostate cancer, and then we have another shoulder talk. I do want to remind folks that next Wednesday is Veterans Day, so there'll be no medical grand rounds. There is a grand rounds the following week regarding thrombosis and COVID. Sorry, Larry, I forget the name of the speaker. And then next Thursday, we'll have a talk on prostate cancer. And then the following talk will be shoulder. So everyone go ahead and enjoy some nice weather today, and hopefully we'll get an answer on the election by the end of the week. Would be nice. Tim, thanks again for the time and the pictures and the history lesson. Everyone have a great day. Have a nice Thursday. Bye.